First of all, thank you very much for having me here at your National Congress. I'd like to speak today about how we have implemented AI, particularly around chest x-rays, at a very large scale in Australia. These are my disclosures. So let's start by talking about how AI can help us in radiology. We like to break down the benefits into those which make us more efficient and those which make us better at doing our job. So we talk about making a more efficient workflow, and we talk about reducing the time it takes to do our reports. The patient outcome benefits allow us to detect and treat pathology sooner. It allows us to try to reduce the amount of radiation dose and volume of contrast that we give. It makes our reports more accurate and eventually allows us to produce some personalised medicine. So when we talk about how we use AI, we need to think about how we make decisions in radiology. Right now, we have the human looking at the imaging and making a decision. There's also the option of having the AI algorithm look at the imaging and make an output or a decision. And really what we're doing in my company in Australia is we are starting to use them in combination. So the AI is one of the inputs that the radiologist uses to make the decision about how we interpret those images. So this is a really important point about anyone who is thinking about implementing an AI product, and that's about how to decide whether the AI is right for your department. So one thing to do is to have a look to see how much evidence is out there for that particular AI product. And the first question is, how does that AI product perform compared to some sort of ground truth or gold standard? And we can also look to see how does the AI compare to a radiologist. Really important information is how does the radiologist performance change when they have access to the AI? Because we are starting to use AI now as an assistant to the radiologist. And check to see whether the evidence has been generated in a patient group that is similar to your patients. You should check the performance of the AI on some of your own cases. You should try to set up a test environment to check that it will work in your own IT infrastructure, and have a small group of your own doctors test it to see whether this is something that will be beneficial for your department. Unfortunately, there's not a lot of evidence for many of the AI products that are out there. Only 18% of AI products published by April 2021 had any evidence about how the AI changes the radiologist's performance. So I'm going to use Annalise as a chest X-ray AI example. It's been developed in Australia by a team of very talented clinicians and software engineers. In addition to that, the labeling done for this algorithm has been performed here in Vietnam. So many of the Vietnamese radiologists have been assisting us with our labeling. And we have taken training data, not from Vietnam, from around the rest of the world, to train our algorithm on nearly 1 million chest x-rays. Because we've had such a large data set and such a large team of labelers, we've been able to produce a model that is very comprehensive. And this is 124 findings. And the reason that this is important is that it allows us to do things that other less comprehensive models can't do. It allows us to do work list prioritization, and it allows us to investigate particular use cases that might be relevant to your hospital department, but not relevant to somebody else. So it's very flexible. And because I know that many of you have not used AI before, I'll give you an example. And this is how any AI product could be integrated into your workflow. These patient names have all been randomly generated. They're not real patient names. Here is a case of a chest X-ray. This is what happens when the AI pops up. It shows you where the pneumothorax is. Now, it would be easy to miss the pneumothorax if you weren't expecting to see it, particularly if you're the doctor working in the emergency department. As well as that, it shows you where the rib fractures are. And the rib fractures are less easy to see on the chest X-ray. Here is another example. We have a patient here, again with a frontal chest X-ray. And this has shown that there is an opacity, probably pneumonia, in the left base. The AI will show you where it is with the overlay. And as well as that, it shows you where the simple effusion is associated with that pneumonia. It's also important because a lot of chest X-rays come with a lateral view to look at all of the available projections. So it will also show you where the abnormality is on a lateral view. Now, I know lots of the questions we have here in Vietnam relate to TB. And there's going to be a talk coming soon about TB, which I'm looking forward to hearing. But we have a lot of findings that are relevant to TB on chest X-ray. These are all of the relevant findings that we can include to talk about TB. And we can demonstrate where the opacity is, we can demonstrate the fibrosis, we can talk about the miliary lesions. So it's important when you have such a comprehensive list of findings to know what it is that's important for your department, whether TB is important, whether it's trauma, whether it's inpatients, whether it's lung cancer, to have a very clear idea about that before you implement the AI. Here is a great example of a patient who presented for another reason, but happens to have a small lung nodule. And this was missed by the radiologist who reported this. In retrospect, it is clearly there, and the arrow points it out very well, but it's hard to see if you are not looking for it. And it shows it again on the lateral projection. What it also shows are some of the other findings that may be relevant to the patient's long-term care, such as the spine wedge fracture, right there. So when we look at evidence, this is an example of some of the evidence that you should try to find. There are some copies, I think, in the room right now, but trying to find a case study looking at the improvement or the change of radiologist performance is really important, and it should be done in a peer-reviewed journal. It demonstrates that the radiologist, compared to the AI is better at detecting the findings for most of these urgent findings compared to the radiologist alone. But of course, the radiologist has access to the previous history, why the patient's presented, the clinical context. So the radiologist uses all of those things. So what we do is we say, let's look to see how the AI affects the radiologist's performance. And that's where we bring in this kind of evidence to say that the radiologist's performance significantly improves when we have access to the AI. So all of this evidence we took into account at IMED, where I work, before we decided to implement this across our entire network. So IMED is a very, very, very big company. We have more than 250 clinics. I think it's nearly 300 clinics. We have hospitals, and private clinics. We have 3 PACS systems and 3 different RIS systems. This is a complicated IT environment. We also have more than 350 radiologists to train how to use the AI appropriately. That is a challenge. So how do we do it? How do we deploy at such a large scale? We start with the product. We think about the users of the product. We talk about how we integrate it from a technical perspective, with the goal of how we improve our radiologist accuracy without having to change the existing IT infrastructure. So the product, it's comprehensive. It integrates with the PACS and with the RIS, and it has a separate viewer. They're the key things we need to know from a deployment perspective. The users, it's a large network. It's very diverse. We're all busy. We don't want to spend time wasting time with AI. And many of the radiologists knew nothing about AI. And the integration, many sites, multiple PACS, multiple RIS, different IT infrastructure in different clinics, public system and private health, very different in Australia. So how do we approach the change management? Because that really, when the evidence is good enough, then the question is, how do we change? First thing is engagement. Second part is discovery. Then we do the IT integration. Then we have a pilot group, a small group of users, to test it. Then we adopt it in a small number of users in real practice. And then we roll it out for ongoing adoption. And I'll go through these now. The early engagement. This is so important to identify your key stakeholders. For us, this was our chief radiologist and our chief executive officer, the key stakeholders in the company that I work with. I'm the head of AI, and I had to go to my CEO and my chief radiologist to get their support to even begin this project. You need to bring in your operational team. Do you have a general manager? Do you have a hospital manager? Those people are absolutely vital in executing all of the change that will occur outside the clinical and IT team. Your senior trusted radiologists are absolutely key because they will make an opinion and the other radiologists will follow. So engage with them early. And never, ever, ever forget the IT managers, because they will be the success or the failure of any IT integration. So bring them in early. With the IT integration, we identified the different components of the AI product. We configured our PACS to automatically route cases to the AI. And then we deployed the viewer software to our radiologists. And that sounds very simple, but it was strong engagement from the IMED IT department and the Annalise integration team made that happen very smoothly. So your IT team is very important. Then we did some testing on our own patients with our own doctors. We had 11 consultant radiologists test this in real practice for 6 weeks. And we had nearly 3,000 patients, every chest X-ray patient that these 11 radiologists reported for 6 weeks. And I ran this as a research study with ethics approval. And one of the questions was, did this change your report? And the radiologists answered this question for every single case. Did this really change your report? And the answer was, for about 3.5% of the time, it did. That's 1 in 30 patients. When we looked at our more junior radiologists, less than 5 years, finishing training, that number was 5%, 1 in 20. The radiologists admitted it changed their report. That was huge. Then we asked them for every case, did this affect the patient management immediately? And they said 1 in 70, it did. 1.5%. That's a pretty big number. It changes what happens straight away because the AI told them something else. Equally important, the radiologists like using it. 90% of them said it made them more accurate, and they felt more positive towards AI after they used it for 6 weeks. This was very encouraging to us. This has been published in the British Medical Journal, and it's free to access if you'd like to see how we did this. But we asked a lot of questions at the end. They were mostly very satisfied with how they made the accuracy as well as their reporting time, and their attitude towards this AI and AI overall improved towards the end of the study after 6 weeks. This is the user survey that we did at 3 months. And this is a question now of all of our radiologists across the whole network, more than 300 radiologists, where we said, do you still use the AI? And 93% of them said yes. That was huge. So it's important when you roll out a big project like this to check the users for ongoing engagement and positivity, and to find out if there are any problems. About half of them said that they were comfortable using it in less than 5 cases. And that is really because we did a great job in doing some training videos, training sessions with groups as they started using it, to make sure that they felt comfortable and they had a chance to ask questions. Really important. Of course, we want to be sure that it's not going to make them any slower, because we are all very pressured to get through more work. 75% of them felt that it made them no difference, and 25% said it made them faster. And 90% of all the radiologists said it has positively improved their reports. That was a huge number, which we were very happy about. So we then said, well, seeing as chest X-ray went so well, let's try it now with CT brain. And this is a very new thing. It's been only about 6 months. So we're using, again, an Annalise model, very comprehensive, 130 findings. And importantly, it covers the trauma. It covers the infarct, the stroke. It covers the bony changes. It covers loads and loads of things. And I'm a chest radiologist. So I use this, and I am so happy to use it, because it helps me, because I'm not a neuroradiologist. It helps me more than my neuroradiology colleagues. We did exactly the same thing. We did some user testing, user training, engaged the IT department. Again, they've done it once before, so the second time is much easier. And we asked our radiologists how they felt about it. And they said, how does it compare to the other AI for CT brain? And 100% of them said it was better than what we had before. That's the question you want to know. How would you feel if we took it away? They would not be happy. Very important for us to know. Did it speed you up? Did it make you faster? 60% of them said that they were faster, and this was within just 6 weeks of using it. It was easy to use, and 90% said that they were more accurate. All of these pieces of feedback we need to know before we decide to carry on. Really important to get feedback about the use. So what do we currently do? This has now been 2 years since we first implemented the chest X-ray product, and 6 months, roughly, maybe 9 months now, since CT brain. We now use the AI to do triage or prioritization of our work list. So that means anything that is urgent or a critical finding gets a flag for us to report it next. Of course, that means that the bleed in the brain and the pneumothorax get reported faster. I always say to people, when everything is written urgent on the referral, then nothing is urgent, because you don't know where the real pathology is. We use the AI to tell us which cases are urgent. We are faster. We have just proven with we've been accepted to present this at RSNA this year, that we are 10% faster when we report our CT brains using AI. Our turnaround times have overall improved, especially for urgent cases. The patient outcomes are better, but most importantly, we as the radiologists are happier. Because when radiologists are happier, they are more productive. So in quick conclusion, AI can help us across our specialty in almost every part of the patient journey through radiology. It is important to ask questions about any tool, especially AI. Ask to see the evidence, ask to see about accuracy, find out what level of support you can get from the AI company, and find out how reliable it is with integration. Most importantly, remember that the AI is there as a tool to make you more accurate, more efficient, and happier. Thank you very much.